The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Growth and development is just like immunization. You have to know the principles, but you also have to memorize. It's a continuous process, and this is very important. The development is cephalocaudal proximodistal. So from head pababa, okay, and from the center going out. And one clear example of this concept is your motor development, diba? It starts from the head, neck, diba? So nagkakaroon ka ng turning of your head from side to side, okay? Head control, okay? And then it goes down to the chest. You can turn your chest, which makes the baby can now, from head control, the baby can now roll over. And then your abdominal muscles will develop and the hip muscles, which from rolling over, the baby can now sit with support and then without support. And then the thighs will develop, the baby can crawl. And then the legs will develop, the baby can stand. And finally, the baby can walk. So it's cephalocaudal. It makes sense, diba? But do remember that the rate varies from child to child. So usually for the first year of life, it's plus or minus 2 months. And for the second year onwards, it's around plus or minus 4 months. It's very important because again, it's not always na 5 to 6 months ang rolling over. So pwedeng earlier by around 2 months or later than around 2 months. But then again, you have to memorize and also remember yung mga tinatawag nating red flags. Okay? So please remember that. Delay is when the child's development is not as advanced as it should be, and usually it's always compared with other children. So kino-compare yan. Kaya tayo nagkakaroon ng mga arbitrary figures na 4 to 6 months. Okay? And again, the lesson here is, for the exam, of course, they will ask you anong month yung ganito. But in practice, actually, we take a look at it as a whole. So for example, yung anak ko, nung time na nasa 6 months old pa lang siya, hindi pa siya nakaka-roll over, medyo nag-freak out na ako. Okay? But everything else seems to be normal. Lahat normal, weight, height, other milestones. But the rolling over, hindi niya pa makuha at 6 months. Is that considered a delay? Syempre, hindi. Okay? Pasok pa yon. Kasi again, plus or minus 2 months. And then, yun lang, nag-aalala yung tatay. So, ginagawa, pag dinakatingin yung misis ko, tinutulak ko siya unti-unti. Uy, mag-roll over ka na. Okay? So, again, it's a spectrum. Please remember that. It's a spectrum. Okay? So, you have a mother of an 8-month-old child na nag-aalala si mama niya, bakit wala pa raw ngipin yung anak niya? Because, usually, okay, commonly, the tooth eruption happens at what age? Usually, it happens at 6 months at a rate of 1 tooth per month. So, 6 months, may isa yan, tapos 7, isa ulit, 8, ganyan. For 8 months old, wala pa. Unremarkable history, otherwise, well, what will you advise? Okay? Should you be working up for hypothyroidism? 8 months, wala pang ngipin, pwede pa ba? Sabi natin, plus or minus 2 months, dok, pasok pa siya. Okay? So, sabi, abnormal to dahil dapat at 8 months tunay yung ngipin niya. So, actually, pwede pa. Pasok pa siya. Should you do an x-ray? At this point, not really. You should only observe and reassure because, again, at 8 months, pwede pa yan. Okay? Plus or minus 2 months. Okay? Paano pag 10 months, wala pang ngipin? Pwede pa ba yun? Yes, pwede pa yun. Paano pag 12 months? Actually, pwede pa yun. Okay? Dok, akala ko pa plus or minus 2 months. Again, sabi ko sa inyo, that's a general rule, but there are specific rules. And for tooth eruption, you suspect thyroid disorder, you suspect a problem, actually, the limit is around 13 months. So, up to 13 months, pwede pa siya. Okay? Number of teeth, sinabi ko sa inyo yan, formula is 18 months minus 6. So, pag 8 months minus 6, that's around 2 teeth dapat siya at that time. But again, there are exceptions, there are, what do you call this? There are room for adjustment. So, hindi siya fixed na ganun. Kumbaga, estimate lang yan. Okay? So, it usually begins at 6 months of age. Ang unang tumutubo, tinatanong sa exam palagi yan, it's usually your central mandibular incisors. So, dito, sa baba. Okay? And by 3, most of your primary tooth have erupted. Okay? This reflex is eliciting by supporting the infant in a semi-erect position, allowing the infant to fall, which is followed by extension, abduction of fingers and extremities, and then flexion and audible cry. We all know this. We've discussed this. This is your Moro reflex. Okay? Alam na natin yan. Please memorize this table. You should know when the reflex will appear and more importantly, when they will disappear. Again, these are primitive reflexes, meaning as you grow old, these reflexes dapat nawawala yung mga yan. If these reflexes persist, then that is considered abnormal. Favorite in the exam is Moro reflex and tonic neck reflex. Moro reflex should disappear by 5 to 6 months, followed by tonic neck reflex. Okay? Other important reflexes that you should know, the grasp response is elicited by placing your finger in the palm of the baby's hand, and what will happen is that the baby will grasp your hand. Okay? So, yan yung grasp reflex. Tonic neck is produced by rotating the infant's head to one side. Okay? On the side where you rotated it, the ipsilateral hand should extend and the contralateral hand should flex like this. So, para siyang nagfe-fencing position, and dapat pag binalik mo sa gitna, dapat babalik din siya. Okay? Dapat babalik siya. Kapag hindi siya bumalik, that is what you call obligatory tonic neck response. Okay? Obligatory tonic neck response is when the infant becomes stuck in the fencing posture and it is always considered abnormal. Alright? The next segment, we will discuss about autism versus ADHD, the two most common developmental abnormalities in children that you will encounter. And it's not so easy. I mean, it's not so hard to differentiate between the two. You just have to know the keywords that you should be looking for during the exam. So, for example, in this question, which among the following is not a key feature of autism spectrum disorder? So, deficits in reciprocity, meaning pag kinausap mo, kakausapin ka niya. Pag tinignan mo, eye contact. Okay, that's what you call reciprocity. Okay, that is a key feature of autism. Deficit in non-verbal communicative behavior. Remember, ano bang picture ng mga batang may autism? Di ba? Parang mapag-isa. Okay, ayaw makipag-interact, may sariling mundo. And yes, they have deficits in non-verbal communicative behavior. They do not know how to point. They do not know how to tell what they want. Okay? Restricted pattern of behavior. Restricted and repetitive. Kaya nga, di ba, yung toy car nila, yung toy train nila, lagi nilang pinipila, paulit-ulit, hindi sila nagsasawa. Those are all features of autism. Impulsivity, on the other hand, is a feature more commonly seen in ADHD. So you have your DSM-5 criteria. Autism, remember this, is characterized by deficits in two core domains, which is social communication and interaction plus restricted repetitive behavior. Etong slide lang ang kailangan nyo tandaan. Ganun kasimple lang yan. When you talk about autism, the patient has deficits in communication and interaction plus restricted repetitive behaviors. The next few slides are just nitty-gritty details on those deficits. So, wala silang reciprocity. They have difficulty and failure in back and forth conversation, sharing of emotions, interest, or affect. Okay? Sabi mo, Dok, parang ako yun na. Mapag-isa, ayaw ko nakikipag-interact with other people. Okay? Remember, for these disorders, for these diseases, the deficits should be significant enough to affect daily living. It should be significant enough to prevent the patient from living normally with other people or with society. So kung feeling niyo ba pag-isa kayo, may mga repetitive behaviors kayo, baka hindi pa autism yan. Okay? And then here you have it. Deficits in non-verbal communicative behavior. When a child wants something, what does the child do? Usually, the child will point. That is what you call your proto-declarative pointing. So again, proto-declarative pointing, children with autism, usually they do not have that, okay? Maintaining and understanding relationships, they have restricted repetitive behavior, lining up of toys, echolalia, flipping of objects. They insist on sameness. They are inflexible to changes in routine. Pag nabago yung routine, usually nagagalit sila.
Make mo ng big bubble.
Big bubble? Okay. Big bubble. So yan, si Ino, nag-hand flapping siya, autism. Alright, okay. So, yan. So, they insist on sameness. They are inflexible to changes in routine. They have restricted and fixated interests. Okay? Hyper or hyporeactivity to inputs. That's the reason why patients with ASD usually pag iba yung environment nila, blinking lights, sudden noise, Usually yan, nagta-temper tantrum sila, tapos nag-breakdown sila because they have difficulty in processing this information. Okay? Even normal conversation. Kaya itong mga may ASD, pag nilabas mo sila sa restaurant, hirap na hirap sila mag-adjust because they might have hypersensitivity to those sensory inputs. Okay? These symptoms must be present early in the developmental period. It should cause significant impairment, and it should not be explained by other diseases or intellectual disability. Okay? So, for ASD, the best established prognostic factor is the presence or absence of intellectual disability and language impairment. So, if the patient does not have these, then there's a chance that some of these patients with ASD could be highly productive. So, I have seen patients na may ASD, pero they're able to go to school, they're able to go to work, and that is possible, depending on the deficits that these patients have. Let's now go to ADHD. So we have ASD, we've discussed that. Now we have ADHD. There are changes on the DSM-5 criteria. The age of onset, they changed it. Several inattentive or hyperactive impulsive symptoms present prior to the age of 12. Dati 6 yan eh. So ngayon, age of 12 na. Tapos dati may specific number sila, pero ngayon basta meron kang several of these features na na-attain, pwede na siyang maging diagnosis for ADHD. And a comorbid diagnosis is allowed. Ano bang kwento ng batang may ADHD? Yung mga patients ko guys na may ADHD sa clinic, di mo makakalimutan yan. Yan yung mga patients na pagpasok sa clinic, sobrang likot ng ikot, hindi mo sila makausap or mapaupo. Tapos yung ibang patients ko, umaakyat sa lamesa, umaakyat sa bintana. Sa school, when they grow up, ang kwento dyan, ito yung bata na laging may bulate sa puwet. Sabi ng teacher, bakit may bulate sa puwet? Kasi parang kiti-kiti, tayo ng tayo, okay? Lahat ng classmate niya nagsosolve ng mga problems, lahat ng classmate niya nag-aaral, siya biglang tatayo, iikot, magwawalis, maglalaro, okay? They are very impulsive, so salita ng salita. Kahit hindi kinakausap, nagsasalita. Okay? Hindi pa tinatanong, wala pang tanong, may sagot na siya. Okay? Sobrang bibo. Sagot na sagot, wala pang tanong. Tapos, habang sinasabi ko ito, sabi mo, shit, parang ganun ako, doc, ah. Okay? So again, it has to be impairing levels. It has to affect the daily living of the child. Okay? So, sabi natin kung yung ASD, impairment of socialization and communication, as well as yung restricted repetitive behavior, in ADHD, it's characterized by impairing levels of inattention, disorganization, and or hyperactivity, impulsivity. So please remember that, okay? So, inattention and disorganization, unable to stay on task. Pag mga simpleng task kaya nila, pero pag mas mahirap katulad ng math, medyo ayaw na nila yon, okay? Losing materials that are levels that are inconsistent with age, okay? Fidgety, inability to stay seated, okay? And these symptoms should be excessive for age and developmental level. So, the next few slides are the nitty-gritty. So, again, 6 or more of the following. So, tama. So, dati 6 years old, ngayon 12 years old na, pero kailangan pa rin pala yung 6 or more. 6 or more of the following. So, fails to give close attention to details, okay? Difficulty sustaining attention in task or play, does not seem to listen when spoken to directly, does not follow through on instructions, and fails to finish schoolwork. So pag mga mas complicated yung task, mas nahihirapan na sila. Organizing task difficulty, dislikes or reluctant in task with sustained mental effort. Loses things unnecessarily. So, Doc, laging nauubos yung pencil ng anak ko. Yung ballpen niya, hindi tumatagal ng isang araw. Parang kilala ko yung mga yan, okay? And distracted by external stimuli and forgetful in daily activities, okay? And then you have hyperactivity and impulsivity, fidgeting, leaving the seat, running around, so forth and so on. Okay, blurts out answers before questions have been completed, difficulty awaiting turn. These symptoms should be severe. It should be present in 2 or more settings. Okay? Dapat present siya sa school, sa work, hindi lang puro sa school. Baka mamaya ayaw lang talaga ng bata ng school. So may mga ganung factor. So it should be present in 2 or more settings. It should interfere with the quality of life and should not be explained by other mental disorders. Okay? The therapy is multifactorial, multidisciplinary. You can give medications, okay? And usually it involves your psychologist, occupational therapist, and other management methods. And again, this table summarizes the difference between autism and ADHD. Autism, again, remember 2 core domains: social, communication, and interaction. plus restricted repetitive pattern of behavior. Sa ADHD naman, impairing levels of inattention and disorganization, and hyperactivity, impulsivity. Very different. So ngayon, alam nyo na yan. Pag tinanong sa inyo sa exam, alam nyo na that di nyo na magpapalit yung autism versus ADHD. Okay, let's discuss gastroenterology. The most common cause of viral gastroenteritis is, so in Pedia guys, sobrang daming ganitong tanong. Always remember when they ask you the most common cause of something, ganyan, dapat ma-memorize nyo yun. And when we're talking about infection, for example, the most common cause of respiratory tract infection, upper respiratory, lower respiratory tract, okay? The most common cause of gastroenteritis, the most common cause of rashes, the most common cause of fever. A lot of times, the answer would be that these are your viruses, okay? Majority of infection in children are viruses, okay? And that's also the reason why for a child who is having an acute illness, hindi left and right dapat nagbibigay ng antibiotics, okay? So for example, most common cause of viral URTI, upper respiratory tract infection, that is your rhinovirus. Okay, please write that down. Okay, rhinovirus. Most common cause of viral pneumonia, pag lower, that is your RSV, your respiratory syncytial virus. So, RSV sa baba, rhinovirus sa taas. Huwag pagpapalitin yun. Okay? And again, going back to the question, most common cause of viral AGE, gastroenteritis, okay? Here's a tip. Pag ang bata nagtatae, ang unang iisipin, rotavirus yan. Okay? Lalo na pag less than 2 years old. Okay? So, technically zero, pero usually newborn, hindi ka muna mag-iisip ka muna pag may newborn na nagtatay, mag-isip ka na ibang cause muna. Baka mamaya, infection yan, bacteria, ganyan. So, probably 2 months up to 2 years, 2 months up to 2 years nagtatae yung bata, even beyond 2 years old. Basta, ang dictum ko dyan is, bata nagtatae, okay, ang unang iisipin, unless proven otherwise, ang unang iisipin is rotavirus, okay? By definition, diarrhea does not last longer than how many days? So, acute diarrhea does not last longer than 14 days, okay? So, nabanggit ko to sa inyo, pediatricians, we love the number 14, okay? So, acute phase ng, for example, acute phase ng Kawasaki disease. So, that's usually around 10 to 14 days, okay? Tapos, acute diarrhea, 14 days. So, mga ganyan. Pag dumating sa exam, nagtanong ng time frame, time period, tapos hindi nyo alam yung isasagot nyo, and nasa choices yung 14 days or 2 weeks, then probably that would be the answer. Okay? Of course, mas maganda kung memorize natin, pero pag manghuhula tayo, then 14 days. We love 14 days. Later on in the discussion, makikita nyo yan na 14 days is a significant number in Pedia. Okay? So, excessively loose stool, technically, basta nagtatae yung bata. Okay? Sudden onset. But if you want to be nitty-gritty about it, by definition sa libro, it's more than 10 ml per kilogram per day or 200 grams per 24 hours in older children. It should last less than 14 days kasi pag more than 14 days sila, and that would be considered chronic or persistent diarrhea na. Pag chronic or persistent diarrhea na yan, marami na kayong ibang differentials na papasok. Papasok na dyan yung lactose intolerance, papasok na dyan yung mga infectious causes of diarrhea, papasok na dyan yung mga ibang sakit, okay? Ibang mga sakit na pwede mag-cause ng chronic diarrhea such as tuberculosis, dami yan, okay? Alright, so you have a patient presenting with inflammatory diarrhea or dysentery. So sabi ko sa inyo, bata nagtatae rotavirus, okay? Ito, ngayon may dugo. Pag may dugo, pag dysentery, malamang hindi na yan rotavirus. Okay? May mga ibang differential diagnosis ka na. Okay? Batang nagtatae, walang dugo, rotavirus. Batang nagtatae na may dugo, the first differential that should come in mind is, okay, it's not amoebiasis, it is Shigella. Okay? So, maliwanag ba yun? Okay? Batang nagtatae na may dugo, usually Shigella yan. Okay? So, I'm sure this situation is very familiar with you and I have a question for you. So for example, sa OPD, sa ER, sa ambulatory clinic, may pumunta sa inyong pasyente, diarrhea, tapos may blood. So yun yung kwento ng mother. Nagtatay yung anak ko, may dugo. And then, naalala nyo yung tinuro ko sa inyo, okay, so sabi Shigella yan. So malamang Shigella, the drug of choice is ciprofloxacin. So sinabi mo na sa mother, Mami, mukhang pwede natin gamutin to as OPD. We will give oral ciprofloxacin. Again, take note that ciprofloxacin is a fluoroquinolone. So pharmacology cross-bridge tayo. Pag fluoroquinolones, we usually don't give that for children less than 7 years of age because there's a risk of inducing or having a damage on your bones and your cartilage, diba? So one of the toxicities of fluoroquinolones. But mind you, even if your patient is less than 7 years old, as long as you're giving it at the therapeutic dose range, those chances of having cartilage and bone damage are very small, very slim to none. As long as tama yung dosing nyo. So, but you still have to explain this to the parents, and if you have other alternative medications, then of course you can give them. So, Shigella, alternative medications would be cefixime, okay? Pero the drug of choice, again, is ciprofloxacin. So, going back, gagamutin mo na yung bata, you're going to give ciprofloxacin, pero biglang naglabas yung mother ng result ng stool exam. Magaling si mother, nagpa-stool exam siya on her own. Very common, di ba? We see this a lot. And then, nakasunod dun sa stool exam, +++, 3+, entamoeba histolytic cyst. So, here comes the dilemma. Do you treat this as Shigella, you give ciprofloxacin, or do you treat this as amoebiasis, wherein you will give metronidazole? And a lot of you, your answer would probably be, okay, to, Doc, pwede bang both na lang bigyan ko ng cipro sa metro? Wag ganun, guys. Pwede shotgun. Pili kayo. So, I think most of you will answer amoebiasis, and this is what happens in practice as well also. I see this a lot. So, again, guys, please remember, the answer should be ciprofloxacin because this is still Shigella. Okay? Shigella pa rin yan. Okay? Entamoeba histolytic cysts, most of the time contaminant yan, or because yung cyst na entamoeba histolytica, marami siyang kamuka, napagkakamalan siya. Okay? Before you diagnose this as amoebiasis, and it's not really that common, around 30% lang, remember, you should be having your trophozoites with ingested RBCs. Okay? So, unless you see trophozoites with ingested RBCs, then probably bloody diarrhea, children, probably that is a case of Shigella. Probably you should be giving your ciprofloxacin. Okay? Please remember that. Abdominal cramps, systemic toxicity after antibiotic use. This is textbook question, pharmacology. Nagbigay ka ng antibiotics. Ampicillin, okay? One of the notorious drugs that triggers this reaction or this illness. So, ampicillin, clindamycin, pwede. Second generation cephalosporins. The drug of choice for this is your metronidazole or vancomycin. Anong sakit to? Caused by your Clostridium difficile. This is your pseudomembranous colitis, your Clostridium difficile colitis, CDC colitis, okay, or your pseudomembranous colitis. Again, drug of choice is Metro and Vanco. Triggers usually are Clinda, ampicillin, and second generation cephalosporins. How common is this? I've only seen one case, so hindi siya ganun ka-common. Abdominal cramps, tenesmus, pus in the WBC. So if you see that, bloody stool, abdominal pain, tenesmus, masakit pag dumudumi, tapos may pus and may blood sa stool, then again, most common cause of dysentery in children, that's Shigella. Ito, sobrang kakaiba yung symptoms, signs and symptoms. One of the great mimickers, confusion, meningismus, nagsisissure siya, minsan nagre-renal problem pa siya. And then you have a history of eating raw egg, unpasteurized milk, poultry, and then think of salmonella, okay? Salmonella or typhoid. Diarrhea after eating hamburger, that is a board exam question. Bloody diarrhea, hamburger, magti-trigger siya ng HUS, hemolytic uremic syndrome. This is your EHEC, enterohemorrhagic E. coli. Okay? Abdominal cramps, watery diarrhea, okay, sweating, walang fever. And then ang kinain ng pasyente is ham, potato salad, and pastries. Think of staphylococcus. Reheated fried rice, are you serious? Bacillus cereus, cereus. Muscle weakness, diplopia, blurring of vision after eating home canned food. Think of your botulism, your botulinum toxin. Okay? Other important things to remember with Bacillus cereus, bakit siya sa reheated fried rice? It's because those bacteria, Bacillus cereus, they form heat-resistant spores. So, may spores sila na heat-resistant. So, kahit painit mo yung fried rice, nandun pa rin yung spores. So, magkakaroon ka ng symptoms. Okay? Staphylococcus, so important dito. Guys, pag tinanong kayo, pag yung pasyente nagtatae, probably kailan niya nakain yung causative organism? Was it this morning, last afternoon, yesterday? A lot of times, these microorganisms would have an incubation period of around 12 to 24 hours or 8 to 24 hours. Why is it significant? Meaning, pag nasira yung tiyan mo, the probability na ano yung nakain mo is nakain mo siya baka nung isang araw pa or kahapon pa. Okay? Bihira yung nakakain ka ngayong lunchtime tapos nagtae ka agad because may incubation period pa yan. Okay? Unless lahat kayo nagtae. Okay? But for Staphylococcus micropara will tell you that Staphylococcus has preformed toxins. Meron silang preformed toxins. And why is it important? So, Staphylococcus, isa siya sa mga notorious na nag-birthday party, tanghali, hapon pa lang nagtatain na lahat ng bata. Then, if that's the case, mabilis masyado yung incubation period kasi may preformed toxin siya, then think of Staphylococcus. Okay? Other important reminders when it comes to diarrhea, batang nagtatae, again, without blood, think viral, less than 2, most common is rotavirus. May dugo, think of Shigella. The drug of choice for Shigella is ciprofloxacin. Okay? And the definitive diagnosis for Shigella is your culture. Right, 8-year-old male was brought to the clinic for diarrhea with bloody, watery stool. 3 episodes of diarrhea accompanied by fever, vomiting, and abdominal pain, painful defecation, initially watery, then becoming bloody with mucus. That's the textbook description of this disease. No family members or other friend with the same illness. Then, if you have this statement, walang ibang kasama sa bahay na may sakit, you would think that this could be probably bacterial. Okay, not all of the time guys, pero clue ko lang yan. Isang clinical clue na tinuturo ko sa mga students ko. Pag lahat sa bahay naghawa-hawaan, probably viruses yan. Kasi mabilis humawa yung mga viruses eh. Pero pag kunwari, isa lang yung may sakit, yung iba wala, then think of bacterial infection. Okay? Again, that's not a 100% rule. That's not even a 50% rule. Pero clinically, yan yung pattern na nakikita natin. Okay? Mga clues lang yan. So again, textbook, sabi ko sa inyo, bata, nagtatae, may dugo, masakit yung puwet pag tumatae, okay? May fever, then that is Shigella. Okay? It invades your epithelial cells, kaya ka nagkakaroon ng bloody diarrhea. The pathology occurs in the colon. Produces Shiga toxin, which can trigger HUS. But again, the most common trigger of HUS is your EHEC, okay? Your E. coli. Okay? Incubation period of around 12 hours to several days. Communicability as long as the person excretes the bacteria. And we've seen and repeated a lot of times yung clinical signs and symptoms, so please know that by heart. Okay? So, yan, watery initially, then becomes bloody with mucus. Some patient will develop neurologic manifestation. If you develop sepsis, mortality rate is quite high at around 20%. Okay? Other causes of bloody diarrhea, the mnemonics for that is SECSY. Sexy. Okay, sexy. Pero ang spelling, SEECCSY. So, Salmonella, EE, okay, CC, and then S is Shigella, and then Y. So, sexy. SEECCSY. Okay? 10-year-old boy with 9 days intermittent fever, okay, on and off, 39.2 yung pinakamataas, soft stool, abdominal pain, tachycardic, okay, hyperactive bowel sound. There's a very vague tenderness, okay? You want to isolate the causative organism, and then you have these choices. So even if, okay, even if hindi mo alam yung sakit, ang tanong sa'yo, anong best na pang-isolate? Blood, urine, stool, culture, fever of more than 9 days. Dapat may sakit na kayong iniisip dito. Okay, ano ba yung question na iisa lang naman yata sa board exam yung tinatanong kayo na when is the best time to do a culture for this disease? Okay, this is typhoid. Okay, this is typhoid fever. This is salmonella. Okay? Ano pa yung clinical clues? Doc, hindi ko nabasa yung BUS na yan. Blood, urine, stool na yan eh. So, hindi ko alam na typhoid siya. Ano pa yung clinical clues? You think of typhoid if you have patient with prolonged fever. So, fever more than 7 days, typhoid automatic, one of our differentials yan. Okay? So, pag mahahaba yung fever more than 7 days, you think of typhoid, tuberculosis, Kawasaki disease. Yan yung mga differential diagnosis nyo. So, ito, typhoid, usually with GI symptoms, fever, and very vague ang presentation niya. Wala kang ma-pinpoint na focus of infection, then think of typhoid. For the first week, the best test to isolate the organism. Mind you, typhoid is very hard to isolate. Bihirang-bihira kami nakakakuha ng growth. But according to the book, the best time frame for the first week is blood, for the second week is urine, for the third week is stool. So your patient is on the second week na, more than 7 days na siya. So the answer here is urine culture. Okay? So it is transmitted via fecal oral route. The incubation period is 7 to 14 days. Very vague signs and symptoms. You can have meningitis, you can have nephrotic syndrome, renal failure. Sa textbook, sa exam, tinatanong nila yung rose spots, but mind you, only 25% will manifest with the rose spots. Okay? And it's usually visible on the 7th to 10th day of illness and lasts only 2 to 3 days. So kung minsan pag check nyo ng patient, usually wala na yan eh. Okay? If no complications occur, okay, symptoms usually resolve gradually. Medyo matagal nga lang. Complications that we watch out for would be hemorrhage, perforation, myocarditis, meningitis, endocarditis. Okay? The treatment regimen is placed here in the table. So, medyo magulo sa unang tingin sa simula pero wag malilito. Okay? If the patient has uncomplicated typhoid, fully sensitive, chloramphenicol is the drug of choice. Okay? But resistance is high nowadays. So, usually for multi-drug resistant, we give your amoxicillin or fluoroquinolones or your third generation cephalosporins. And for quinolone resistant, we can give your azitro or your ceftriaxone, high dose azithromycin. Okay? 10 milligram per kilogram per day. Okay, for 7 days. Please take note of that. For severe typhoid, fully sensitive, we give your quinolones. Drug resistant, we give your quinolones pag multi-drug resistant. And pag quinolone resistant, we give your ceftriaxone or cefotaxime. So, basically, guys, what is this table is telling you is if you're treating typhoid empirically, hindi mo alam kung drug resistant ba yan or sensitive ba yan, then in clinical practice, this is what we usually start patients when we are suspecting typhoid. We start them with ceftriaxone, your third generation cephalosporins. And then if you get a result of the culture, then maybe probably you can step down your treatment depending on the severity and the antimicrobial susceptibility. Okay? Okay, next case, you have a 3-year-old boy presenting with chronic constipation. So since bata siya, constipated daw siya, which means in a week, less than 3 times yung kanyang pag-BM. So 2 or less, di ba? If you find a boy who looks active and playful, active siya, okay siya, wala namang ibang problema, non-tender on rectal exam, normal tone, no feces. What is your most likely impression? Okay? So, again, eliminate muna tayo dun sa ibang tanong, ibang choices. Ganun yung strategy nyo palagi. Duodenal atresia, you all know that presents usually early on, usually sa neonatal period yan. So, out na yan. Okay? Meckel's diverticulum, usually, it can present with constipation and obstruction, pero usually hindi chronic. Saka ang mas common na presentation ni Meckel's is painless rectal bleeding, di ba? So you're left with 2. Is it Hirschsprung or functional constipation? Functional constipation, ang problem dito guys, psychological yan. Yung bata, pag nasaktan siya dahil matigas yung pupo niya, ayaw niyang dumumi dahil ayaw niyang masaktan. Okay? So, ang nangyayari, iniipit niya yung pupo niya, okay? Tapos, yun, hindi siya nagdudumi, nagka-constipate siya. So, between the two, okay, the better answer here, this would be probably more of a case of Hirschsprung's disease. And what is the giveaway there? Okay? There's a very good giveaway in the exam, in the question. And usually sa exam sa PEDIA, ganyan talaga yung ginagawa nila. May mga buzzwords sila, may mga giveaway sila. Your giveaway here is, yes, both Hirschsprung and functional constipation would present with constipation, but the giveaway here is your DRE, your rectal exam. And look at the exam. You have a patient that is constipated, and yet, on your rectal exam, okay, walang feces. Empty yung rectal vault, which means nasaan yung dumi? Nasa taas, di ba? Because what happens in Hirschsprung's disease is that you have a ganglionic segment, hindi makababa yung dumi papunta sa rectal vault. Naiipit siya sa taas. And that's why, even though the patient is constipated, you do have an empty rectal vault and there's no feces on the examining finger. So, this is probably a better answer for this one is Hirschsprung's disease, okay? And the part of the digestive tract that is affected in Hirschsprung, 80 to 90% would be in the rectosigmoid area. What is the definitive diagnostic test or tool for this disease? Okay, for Hirschsprung, the definitive diagnostic exam would be, okay, and if they ask you most of the questions in the exam, pag nagtanong sa inyo ng definitive test and there's biopsy in the choice, then probably that is the answer. And yes, of course, for Hirschsprung, the gold standard is to do your biopsy to look for that aganglionosis. Okay? So the absence of your ganglion cells in the bowel wall beginning in the anal sphincter. It is more common in males than in females. Okay? So again, this is your normal colon. This is your Hirschsprung wherein you have your aganglionotic cells, and yan, lumalaki yung bituka dahil hindi makababa yung dumi. Naiipon yung dumi dito sa taas. Okay? So if they ask you in the x-ray, which part is the abnormal part? Is it the distal constricted portion or the proximal dilated portion? The abnormal part is actually here. It's in the constriction over here. Okay? So hindi to lumalaki dahil abnormal siya. Lumalaki siya kasi hindi siya makababa dito. So it's the distal portion. Okay? So rectosigmoid, 80% of the time, again, it's more common in males. absence of your Meissner and Auerbach plexus at dahil wala kang ganglion cells, there is decreased motility, decreased propagation or peristalsis, and there's abnormal relaxation. Most of these patients will manifest with delayed passage of meconium. If you have a patient with delayed passage of meconium, Hirschsprung's is one of your top differential diagnosis. And that is why it's very important to know ano ba yung regular period na allowable. In newborn, most of the time in newborns, your meconium is passed within the 24 hours of life. But the limit is actually 48 hours. Okay, so please remember that. Urine output, ang limit natin, dapat umihi yung baby in 24 hours, 1 day. Meconium in 2 days maximum. But for majority of patients, usually within 24 hours may meconium na rin yan. Okay? So if you have a patient 2 days na wala pa ring passage of meconium, then think of obstruction, possibility, think of your Hirschsprung disease, one of your differential diagnosis. Some may present with chronic constipation like the one that we discussed in this case, okay? The problem here is dahil lumalaki, nadidistend, nag-increase yung pressure, nasisira yung kanyang blood flow and mucosal barrier, making them prone to infection or enterocolitis. Diagnosis is biopsy. On X-ray, you might see a transitional zone between the normal and the dilated proximal colon, okay? And the treatment is, of course, surgical. But before you can proceed with anastomosis, which is what we call the pull-through procedure, usually they do a temporizing measure, which is your colostomy, until the infant is bigger, ready to undergo definitive repair. Okay? So isang choice kanina, it's functional constipation. Do take note that functional constipation is a diagnosis of exclusion. So dapat ma-rule out mo muna na walang organic or other pathologic causes. And again, the problem here is psychological. Natatakot yung bata because tumigas yung tae niya, okay, hard stool, there's irritation, ayaw ng batang nasasaktan ng paulit-ulit, buti pa yung bata natututo, yung mga matatanda, paulit-ulit na sinasaktan dyan. Okay? So, there's anal irritation. So, pag natatayo ulit yung bata, iipitin niya. Kaya on history, ano yung mga tatanungin nyo dito? Mami, yung bata ba pag natatai siya sa umaga, parang takot siyang tumae? Yes, Doc. Takot na takot po siya. Umiiyak siya. Kung minsan makikita ko, pupunta siya sa isang sulok ng kwarto, tapos umuupo siya, iniipit niya yung puwet niya para hindi lumabas yung dumi. Okay? And it's a vicious cycle kasi pag inipit niya, titigas lalong titigas ng titigas hanggang lalong mas masakit ilabas. Okay? And we have a criteria for that. It's your Rome 4 diagnostic criteria, okay? And then you have a criteria for neonates, toddlers, children, and adolescents. Pretty much similar. Aralin nyo on your own. Pero tignan natin dito again, 1 month, 2 or more of the following. Okay? So, dapat 1 month duration, 2 or more of the following. Okay? Less than 2 or fewer defecations per week. Excessive retention. Okay? Iniipit yung dumi. Painful bowel movements. Large diameter stool. Okay? Large fecal mass pag nag-DRE kayo, 1 weekly episode of incontinence. So, toilet trained na siya, pero Dok, dumudumi siya. Ang tawag dito is overflow incontinence. Okay? So, dahil sa sobrang dami ng laman ng rectal vault, kahit toilet trained na yung bata, punong-puno yung rectal vault, lumalabas na yung dumi. So, nasa school siya, biglang makakatae siya sa diaper dahil sobrang puno na yung vault ng kanyang rectal vault. Okay? And look at this, a history of large diameter stool that may clog the toilet. So, okay, literal, nandyan siya sa criteria, guys. Okay, Mami, sobrang tigas po ba? Opo, Doc, sobrang tigas ng dumi niya. Minsan, hindi ko ma-flush, nagbabara. Okay? So, if you fulfill 2 or more of the following, more than 1 month duration, then you can diagnose the child having functional constipation. Again, dapat walang other pathologic causes. Okay? So, of course, you have to do your workup. Okay, the treatment is toilet training, dietary modification, very important. Relieve the impaction. And you give stool softener. Please take note that stool softeners for functional constipation, we usually give that for 4 to 6 months. Okay? So, 4 to 6 months, very important kasi I see a lot of patients being given a stool softener for just 2 weeks, for just 1 week. Pag okay na, tigil na. And then the problem is, after that, after 1 week, after 2 weeks, titigas ulit yung dumi, masaktan ulit yung bata, back to zero tayo. Okay? Remember, you have to train the mind. You have to train the mind of the child na may pasok sa utak niya na hindi masakit dumumi. Okay? Hindi masakit tumae. And it will take time. It will take months of effortless bowel movement, painless bowel movement, bago ma-imprint sa utak ng bata na hindi masakit dumumi. Okay, so please do take note again, if you give your stool softeners and you have to give this for at least 4 months, 4 to 6 months, all right? Okay, so patients with obstruction cannot pass the nasogastric tube, severe pain and emesis, omega sign, coffee bean sign. So sudden onset vomiting, villus, there's obstruction, you cannot pass your nasogastric tube, tapos sobrang sakit, okay? Tapos emesis, this is your volvulus, okay? Pag nag-twist around the mesentery yung bituka, okay? Current jelly stool, this is a giveaway, sausage-shaped mass, coiled spring sign, that is your intussusception. Okay, this one is a olive-shaped mass with non-bilous vomiting, meaning your obstruction is proximal to the ampulla of Vater. Okay, on barium study, you see your shoulder sign and your double track sign. This is your pyloric stenosis. And you have normal history or recurrent obstructive symptoms. So, pwedeng constipation. Pero ito yung mas common, painless rectal bleeding. We told you that. Diagnosis is scintigraphy to detect your ectopic gastric or pancreatic tissues na naligaw, napunta sa bituka. This is your Meckel's diverticulum. And remember, for Meckel's diverticulum, we do have a rule of 2 that is very easy to remember, and you always usually ask this in the exam. 2% of the population is affected. 2 years old is the usual presentation. It's more common in males. There had been a lot of debate, different resources saying otherwise. There's a section in Nelson's that may typo error, sabi female, but this is the correct answer, guys. It's more common in males. The defect is usually 2 inches long, located 2 feet from the ileocecal valve. You have 2 types of ectopic tissue, which is gastric and pancreatic, and this rule does not apply to everyone. Okay, so please, very easy to memorize. Memorize Meckel's rule of 2. Again, the common presentation is painless rectal bleeding. Okay, so again, this is your omega sign, your coffee bean, your inverted U, pare-parehas lang yan. This is volvulus. This is your coiled spring sign. You see this in, saan nakikita to? Intussusception. Okay, coiled spring sign. This is your bird's beak. Pag nasa taas, bird's beak, ano yan? That's achalasia, di ba? Bird's beak sa may esophagus, achalasia. Pag nasa puwit yung bird's beak, then think of Hirschsprung. And this is your double bubble sign. You have the duodenal bubble and the stomach. This is your duodenal atresia. Okay? Okay, we're down to the second to the last topic, and we're going to discuss nephrology. You have to know nephrology and the most common diseases that are discussed in nephrology, because in the exam for pediatrics, consistently for the past 5 to 10 years or so, laging maraming tinatanong on nephrology. And gano karami? How many is many? Usually it's around 5 to 10 questions, and that's a lot. That's a lot for the board exam, okay? So for nephrology, you have to know the criteria for hematuria, because you have 2 general problems in nephrology in children. Well, 3. So UTI, okay, and then you have a child presenting with hematuria, and then the other one is the one presenting with proteinuria. Okay, so hematuria by definition is more than 5 RBCs per high power field in a centrifuge specimen. Kapag uncentrifuged yan, it's more than 10. Okay, and then you have to look at the morphology, because that is very important. It can tell you where the bleeding or the hematuria is coming from. Okay, so do take note that there are false negative and false positive causes of hematuria. This is being asked in the exam. May tinanong to mga 3 years ago yata. An alkaline urine and hydrogen peroxide may cause false positive hematuria. Okay? So RBC, again, presence of RBC is suggested by more than 10 RBC per microliter or +1 dipstick in a centrifuge urine. Okay? So pag centrifuge, again, balikan natin yung slide kanina, sabi natin dyan, more than 5 RBCs per high power field or more than 10 RBC, okay, per microliter or +1 in dipstick. So please remember those nitty-gritty details kasi lumalabas sa exam yan. Okay? This slide is very important. Based on your characteristic of the urine, okay, you can have an idea if your hematuria is from the glomerular sa taas, okay, or from the lower urinary tract sa baba. Okay? If you have significant proteinuria, which is around 100 milligram per deciliter, more than 100 milligram per deciliter on your dipstick, okay? And if your urine is brown, cola, or tea-colored, burgundy, okay? And the morphology is dysmorphic, then probably it's from the glomerular level, okay? Such as your glomerulonephritis. But if it is gross hematuria, if the protein is minimal, less than 100, and there's normal morphology, then probably it's from the lower urinary tract, such as cystitis, okay? Cystitis, UTI, trauma, mass, okay? So, yun yung mga possible causes. So, very important, differentiate glomerular versus lower urinary tract sources of hematuria. Look at three things. Again, protein, the morphology, okay, and the description. So again, brown cola, tea-colored, dysmorphic, and more than 100 milligram per deciliter na protein, probably it is glomerular. Okay? 10-year-old male comes into the clinic for swelling or edema. And when you have a patient with edema, the pathophysiology, the organ system that you would think of is heart, liver, and kidneys. In children, very common ang kidneys na cause ng edema, lalo na pag acute edema yan. Okay? She also noticed to be weak and lethargic. Nagkaroon siya ng infected skin infection. Infected skin lesion a month ago, which nagbigay siya ng antibiotic, which is very important because for this disease, even if you treat the infection, it will not alter the chances of you getting this renal disease. So even if you treat your skin infection, even if you give antibiotics, it will not change the course of the disease. Okay? Favorite question din sa board exam yan. Okay? On PE, 130/90, and that is high. That is considered hypertensive. Okay? Even for adults, 130/90 is already considered hypertensive. Again, we do have a formula. For children, guys, if you want to know if the patient is hypertensive, you have to refer to a chart. There's a chart based on the height of the patient and you have their p-values. But that is very cumbersome to do. Kailangan nasa harapan mo yung chart. Eyeballing, we have a formula that we use. Again, not the most accurate. This is for eyeballing it. Age times 2, okay, age times 2, okay, plus 90 would be your upper limit for systolic blood pressure. So 10 times 2, okay, that's 20, plus 90, then that's around 110. You would know that for a 10-year-old, 110 systolic is probably elevated. So ito definitely 130/90, that is high, okay? You have bipedal edema, okay? Tonsils not enlarged on urinalysis. There's hematuria. There's +1 protein, okay? Creatinine is normal. What is your most likely diagnosis, okay? So the first question to ask when you have a case of edema and you're thinking renal, the first question to ask is this nephrotic, glomerulonephritis, or is this nephritic, okay? And I will give you a very good mnemonic. Please write this down. For nephrotic and for glomerulonephritis, okay? For glomerulonephritis, for nephritic syndrome, glomerulonephritis, nephritic, what you will be looking for is hypertension, oliguria, decreased urine output, that's plus or minus, hematuria, and A is azotemia. Okay, azotemia, okay, plus or minus din yon. So, basically, the 2H, yun yung pinaka-important. Usually, they have hypertension and hematuria. Okay, so again, HOHA, HOHA. Okay, so, renal problem, unang tanong, glomerulonephritis ba to? Kung glomerulonephritis, tignan mo, pasok ba siya? HOHA. Hypertension, oliguria, hematuria, plus or minus azotemia. So your patient, pasok siya sa hypertension, pasok siya sa, okay, hematuria, then probably this is glomerulonephritis. The first differential for glomerulonephritis in children is your post-streptococcal glomerulonephritis, PSGN. Okay? So, Doc, walang oliguria. Okay, hindi na mention, pero pasok siya hematuria, tapos hypertension. Okay? Minimal change presents with nephrotic, so that's out. Membranoproliferative and membranous glomerulonephritis, they present with also as nephrotic syndrome. So, the answer is B. Okay? So, look at the choices. Tignan nyo kung saan dyan yung nephritic, saan dyan yung nephrotic. Okay? So, it's post-streptococcal glomerulonephritis. Okay? So, HOHA. So, again, APSGN, acute post-streptococcal glomerulonephritis, it is rare before 3 years of age. The age group is 5 to 12. Age group is very important because if you have you're thinking of PSGN and the patient is less than 3 or more than 12, teenager, probably, baka ibang sakit yan. For example, teenager na babae, glomerulonephritis, baka mas common ang lupus dyan na cause kesa APSGN lang. Pwede pa rin, pero hindi ganun common. And if you have PSGN or glomerulonephritis less than 3, then think of other diagnoses as well. Okay? Clinical spectrum from asymptomatic to renal failure. When you have a patient with renal failure, glomerulonephritis, one differential should come into mind. So for example, nag-glomerulonephritis siya, sabi natin majority will resolve, okay, for PSGN, pero nag-renal failure siya, then think of your RPGN, rapidly progressing glomerulonephritis, okay? To be able to document that this is because of streptococcus, okay? So there are different post-infectious causes of glomerulonephritis, okay? In general, we call this PIGN, post-infectious glomerulonephritis. And the specific one and common in children is PSGN, post-streptococcal. To document that this is post-streptococcal, you can check for your ASO titers if it is from the throat infection, okay? If it is from tonsillitis. But if it is from pyoderma, the better test would be your anti-deoxyribonuclease B. Okay? So, please remember that. Anti-deoxyribonuclease B. Okay? Dahil sa exam, nag-iisip ka ng PSGN, pero mababa ang ASO titer mo, iisipin mo ba, uy, baka hindi to PSGN. Tignan mo muna, saan ba yung source? Okay? Baka sa skin pala. Baka ang dapat i-test mo is our anti-deoxyribonuclease B. And again, what's the causative organism? It's your strep pyogenes. Okay? Your strep pyogenes. Your group B, GBS. No, it's your group A, GABS. Your group A beta hemolytic strep. Okay? Your strep pyogenes. Okay? And again, remember your group A beta hemolytic strep, your strep pyogenes, it causes another notorious disease aside from PSGN, which is your rheumatic fever. Okay, but also take note that rheumatic fever from post-streptococcal infection from strep pyogenes, rheumatic fever will only come from the throat. So tonsillitis or pharyngitis. Okay, so streptococcal pharyngitis will cause or may trigger both rheumatic fever and PSGN, but pyoderma skin infection will only trigger, okay, your PSGN and not your rheumatic fever or rheumatic heart disease. So please remember that. Okay, so you have different serotypes. If it's coming from the throat, it's 1, 2, 4, 12, 18, and 25. It's coming from the skin, it's 49, 55, 57, and 60. Okay? Tinatanong sa exam, manifestation from throat, mas mabilis, usually 1 to 2 weeks after the infection lumalabas. From skin, it's 3 to 6 weeks. Okay? And ito, very important questions tong mga to. Acute phase lasts for 6 to 8 weeks and you can further subdivide the acute phase into 2 weeks. Again, we love the number 14. We love 2 weeks. So, first 2 weeks is your oliguric stage. So, oliguric, hindi umiihi, high blood siya, that's where all the problem arises. After that, the next 2 weeks is your diuretic stage. So, iihi na yung pasyente mo dyan. And then you have the last 2 weeks, which is your convalescent stage. So, that is your acute phase. Do remember that protein excretion, so you can have minimal proteinuria, usually +1, +2. But again, primarily, this is a disease that is more on the nephritic side, okay? And hypertension may last for 4 to 6 weeks, which coincides with your acute phase. Okay? All right. And microscopic hematuria, okay, on your dipstick, you may have hematuria for around 1 to 2 years. That can happen in PSGN. But this is the most important, okay? This is the most important. And this is almost always asked in all the board exam questions, okay? In PSGN, your C3 decreases. And there are only a small set of disease that presents with decreased C3, okay? And that is PSGN, lupus, SLE, and your membranoproliferative glomerulonephritis. Okay, tatlo lang. Okay, other diseases with decreased C3 would be infective endocarditis and shunt nephritis. Okay, so yung limang yon. Okay, so please remember that. So again, differential diagnosis pag mababa ang C3, PSGN, SLE, MPGN, infective endocarditis, IE, saka shunt nephritis, yung limang yon. Okay, and for PSGN, your C3 level is decreased for 6 to 8 weeks. Pero after 8 weeks, dapat mag-normalize na siya. Pag hindi pa rin nag-normalize yung C3 mo after 8 weeks, then probably that is not PSGN. So please remember that. Okay? So management is, again, 95% of this disease will resolve on its own. Okay? Gagaling siya. But you have to do supportive management if your patient is symptomatic, edematous, nag-hypertension, pinakadelikado hypertension. A lot of times you just give your fluid control, fluid restriction, okay? You can give your diuretics, furosemide, and plus or minus antihypertensive drugs. But most of the time, fluid restriction lang yan saka furosemide, okay? For PSGN, we do give antibiotics. We give your penicillin G, PenG, a 10-day course of PenG. Not because it will alter the course of the disease. So please remember that. Your 10-day course of penicillin will not alter the course of the disease, but you give that to prevent the spread of your nephrogenic strains. So balik tayo dito sa isang slide kanina. So you have your strains that are nephrogenic. It will cause glomerulonephritis. So you want to prevent the spread para hindi siya makahawa. But for the patient itself, it does not alter the course of the disease. Okay? So again, please remember, serotype for throat infection, ang pinaka-common dyan is 12. Okay? For skin, it's 49. Okay? And for how many weeks? Again, 1 to 2. And for skin, it's 3 to 6. My mnemonics for this is throat, 12, 1 to 2 weeks. Okay? So, throat, 12, 1 to 2 weeks. From throat infection, it's serotype 12, and the symptoms happen 1 to 2 weeks from the infection. Okay? So, throat, 12, 1 to 2 weeks. For skin, walang mnemonics. Memorize mo na lang. 49 saka 3 to 6. Okay? So, hope that is clear. Alright. Alright, next case. 8-year-old female was brought to you due to swelling of the face. So, swelling din ulit. Nag 24-hour protein collection siya, 5 grams yung result. Mataas yan. Sa adult, ang normal natin is up to 3.5. More than 3.5 grams per 24 hours. Ano yan? Considered nephrotic range proteinuria na yan. Tapos wala masyadong red cells, wala masyadong CAS, nagbigay ng steroids na wala lahat. Most likely this child will have, okay? So again, nephrotic bar, nephritic. Pag nephritic, sabi natin, HOHA. So hematuria, hypertension, parang hindi. Parang more of proteinuria siya, then probably this is nephrotic. For nephrotic, our mnemonics would be PALE. P-A-L-E. Okay? Pero actually, ang pinaka-importante lang doon yung letter P, proteinuria. Dapat pasok siya sa nephrotic range proteinuria. Okay? A is albumin low, so hypoalb, lipids high, hyperlipidemia, and E is edema. Okay? So you know that this case is nephrotic. If we're talking about glomerulonephritis, the first differential is PSGN. If we're talking about nephrotic syndrome, your first differential in children should be minimal change disease. And minimal change disease, 95-90% will respond to steroids. Okay? So, there are different causes of proteinuria. Pwedeng ineffective filtration, reabsorption, or pwedeng increased protein excretion, such as in rhabdomyolysis. This is very important. So in healthy children, your limit is around 100 milligram per body surface area per day or around 150 milligram per day. Okay? And why is this magic number important? Because your dipstick is simply an approximation, but you check the levels here. Plus 1 is 30, plus 2 is 100, plus 3 is 300. So this will tell you that probably plus 1 and plus 2, baka pwede pa yan. Baka hindi pa yan nephrotic range proteinuria. But definitely, if you have a patient with edema, you're considering nephrotic syndrome, and plus 3 or plus 4, then probably pathologic yan. Okay? Do also know that there are non-pathologic causes of proteinuria, such as your postural, febrile, and exercise-induced proteinuria. But most of these cases, pag chinek mo ulit, usually, magbabalik na siya sa normal. And most of these cases, dapat less than 1 gram per day yung excretion nyo. Okay? So, you have several determination of protein, several tests. You have 24-hour protein determination, which is actually more accurate, but the problem is this is very cumbersome to do, and yun, mahirap siya kasi dapat walang tapon. Dapat 24 hours susukatin mo yung wiwi. The downside, the upside on this test is it's more readily available. Okay? And then we have this, another test you call your urine protein creatinine ratio. And this one is faster because we do a spot collection. Okay? And this one, the problem is it's more expensive and not all centers will have this. Okay? Then you have all of these values. Should you memorize everything? Yes, better. Baka itanungin kasi sa exam. But the most important thing to memorize for nephrotic syndrome is actually your nephrotic range proteinuria, which is more than 40 milligram per body surface area per hour. Okay? Or UPCR more than 2. Okay? So please remember that. So most important facts to remember for minimal change disease or nephrotic syndrome in general, there's heavy proteinuria plus 3 or plus 4, UPCR more than 2, more than 40 milligram per body surface area per hour in children, or more than 3.5 gram per 24 hours in adults. Okay? Albumin is low, lipid is high, C3 and C4 are normal, biopsy is not required, 95% will respond to steroids. Okay? If it does not respond to steroids, then probably that is not minimal change disease. Before you give your steroids, rule out tuberculosis first. Uncomplicated cases between 1 to 8 years old are likely to be responsive. If it does not respond, do your biopsy. And if it's not responsive, probably the next differential will be your FSGS, focal segmental glomerulosclerosis. Okay? Again, indications for biopsy, laging tinatanong yan. Ang turo ko sa mga students dito, guys, sabi natin glomerulonephritis. Sabi natin HOHA, hematuria primarily. Pero PSGN ang iniisip mo, pero may heavy proteinuria siya. Then probably that's not PSGN, do your biopsy. Okay? Sabi natin in 8 weeks time, yung mababang C3 sa PSGN dapat nag-normalize na. Pag hindi pa siya nag-normalize, do your biopsy. The same is true with your nephrotic syndrome. Nephrotic ka pero may gross hematuria. Nephrotic ka, nag-hypertension, nagre-renal failure, mababa yung C3. Okay? Or age group na alanganin. Then you do your biopsy. Okay? We give prednisone for 4 to 6 weeks and then you do tapering. Alternate day, magbabawas ka pa unti-unti for 8 weeks to 5 months, meaning the treatment is actually very long. Okay? Mahaba ang treatment for nephrotic syndrome. Okay? But again, a lot of these patients will respond. This is always asked in the exam. You have to know the difference between response, remission, and relapse. Okay? Response is remission attained within 4 weeks of treatment. Okay? Paano mo malalaman kung nag-remission ka? Nag-remission ka if your UPCR is less than 0.2. Okay? So, wag malilito. Yung diagnosis ng nephrotic range is more than 2. Ito, less than 0.2. Okay? Dok, wala kaming UPCR sa baryo namin. You can do 3 consecutive day dipstick. Dapat ang protein mo less than 1. Okay? Relapse, ibig sabihin, nag-respond ka. Pero, bumalik siya ulit. UPCR mo naging more than 2 ulit, or more than or equal to 3 yung dipstick mo for 3 consecutive days. Okay? So, dapat clear yan. Okay. So, here are the different non-responders. Favorite exam question yan. Relapse within 28 days of stopping prednisone. So, nag-remission ka. Naging less than 0.2 yung UPCR mo. Or naging less than 1. Okay? Naging less than 0.2 or naging less than 1. Okay? So, naging trace na lang yung protein mo. Okay? For 3 consecutive days. And then, nag-taper ka. Kaya lang, after 28 days of stopping your prednisone, nag-relapse ka ulit. Pag-check mo, UPCR mo more than 2 na naman. Or, yung consecutive 3 days mo more than or equal to plus 3 na naman. Ang tawag sa'yo, steroid dependent. Okay? Kailangan niya ng steroid. Hindi siya makatanggal sa steroids. Okay? Nag-respond well to prednisone but relapse ng relapse. So, nagre-respond more than 28 days na walang gamot, okay siya, kaya lang pag-check mo after ilang months, magre-relapse ulit siya. This is your frequent relapser, okay? 8 weeks na, di ba? Sabi natin, ang definition ng response is dapat within 4 weeks. Ito, 8 weeks na, hindi pa rin siya nagre-respond. Ang tawag dyan, steroid resistant, okay? Relapse on alternate day. So, nag-treat ka, within 4 weeks, nag-respond ka. Tapos, nagbawas ka ng steroids kasi magte-taper off ka na eh. Nung nagbabawas ka, nag-relapse siya, tumaas ulit yung UPCR niya. Steroid dependent. Okay? Proteinuria after 8 weeks, parehas lang to dito. Hindi siya nagre-respond, 8 weeks na. This is what you call steroid resistant. Okay? So, hope this is clear. I hope you now know how to differentiate between nephrotic and nephritic. Okay? Glomerulonephritis and nephrotic syndrome. So, sabi ko sa inyo, nephrotic, and then nephritic, and then the next most common case encountered in pedia would be your UTI in children, okay? So, in children, we all know that UTI is more common in females, but during the first year of life, actually, it's more of male predominance. But beyond 1 to 2 years old, again, nagiging female siya. By virtue of the proximity of your urethra to the anal opening, because primarily, majority of your UTI infection redundant, majority of your urinary tract infection in children is caused by colonic bacteria. So it is an ascending type of infection. 75 to 90%, these are your organisms, E. coli, Klebsiella, and Proteus. Please remember that, tinatanong sa exam yan. You have 3 basic forms, pyelonephritis, cystitis, and asymptomatic bacteriuria. Pyelonephritis may present with anything and everything under the sun. Okay? Pwedeng fever lang yung manifestation. So, that is why it's warranted. Pag may lagnat ka, walang focus, you can check for your UTI. Pwede ka magpa-urinalysis. Pwedeng fever lang kasi. Pwede rin diarrhea, pwedeng abdominal pain, dami. Okay? Cystitis is lower urinary infection. It involves the bladder. Please take note that it does not cause fever and it does not result in injury. Okay? Asymptomatic bacteriuria, pinapatulan ba natin to? No, unless the patient is a pregnant woman. Okay? Most of the time, it's very common, wala siyang manifestation, hindi siya pinapatulan. Okay? Also know the definition of these terms dahil lumalabas din sa exam siya. Recurrent UTI is 2 or more pyelonephritis or presumptive UTI. Okay? Or 3 or more cystitis or 1 pyelonephritis plus 1 to 2 cystitis. Okay, so mga diagnostic definition lang yan. Presumptive UTI is clinical symptoms plus urinalysis findings not supported by urine culture. Because the next question here is urine culture required for UTI, for the diagnosis of UTI? Okay? And what the book will tell you, what Nelson's will tell you is actually yes. Dapat pag may UTI ka, may urine culture ka. Bakit? Ano bang indications? Pag may significant urinalysis findings. Of course, hindi mo na may diagnose na UTI yan kung wala kang findings. Okay? Complicated UTI. So, paulit-ulit, tapos meron siyang strictures, meron siya for example, comorbidities na nagkukos ng UTI. For example, meron siyang phimosis o kaya may mga renal stones. Seriously ill yung children or recurrent UTI. All of this will require culture. Basically, kailangan mo ng culture. Okay? Kasi kung wala kang culture, technically speaking, ang diagnosis nun is presumptive UTI. Okay? This is also being asked, how do you collect urine? In less than 2-year-old, you do your clean catch urine collection. Okay? Pag more than 2-year-old, midstream clean catch. So, mas maganda kung kaya mo i-instruct na, wag mo munang sasaluhin, midstream clean catch. WBAG, we can use this lalo na pag less than 2, but it is only useful if the results are negative. Meaning, pag malinis yung urinalysis, malinis yung culture, pwede. Okay? Pero, pag positive yung culture mo, nag-WBAG ka, pero may mga tumubo, okay? Maraming tumubong mikrobyo, then you cannot interpret that accurately kasi hindi mo alam kung contaminant siya or hindi. Okay? So again, sabi sa Nelson's, WBAG or sterile urine bag, can you use it for culture? Sabi sa Nelson's, yes, only if the results are negative or, dagdagan nyo yan, you have single isolated organism. For example, urine culture ka, WBAG, may tumubo, isa lang, E. coli lang. Malamang may E. coli talaga yon. Okay? The ideal collection method is, of course, best is suprapubic aspiration or catheterization, but you only do this if and only if the above mentions cannot be done properly because these are invasive methods. Okay? And then we go to your dipstick. In your dipstick and microscopy, you have several parameters that you look for. Nitrite and leukocyte. Look at this table, very important to interpret. Pag positive ang leukocyte, positive ang nitrite, you do your culture, you treat as UTI. Positive yung nitrite, pero negative yung leukocyte, you do your culture, you treat as UTI. Okay? Negative yung nitrite, pero positive yung leukocyte. Culture ka muna, treat only if you have symptoms. Okay? Pag negative parehas, malamang hindi yan UTI. So if you're gonna look at this table, mas mabigat yung timbang ni nitrite. Kasi kahit negative si leukocyte, pag positive na si nitrite, treat as UTI na yan. On microscopy, pyuria is more than 5 on centrifuge urine, more than 10 on uncentrifuge, okay? May bacteriuria ka, may bacteria, tapos may pyuria, culture, treat. May bacteria, walang pyuria, culture, treat pa rin. May pyuria, WBC, pero walang bacteria, okay? Culture muna. Treat kung may symptoms, okay? So again, pag sinabi kong culture muna guys, kunwari wala siyang symptoms, culture muna, okay? Pero pag may symptoms yan, treat pa rin, okay? And pag negative parehas, not UTI. Okay, other tests. When do we do KUB ultrasound? Okay, we do this if you have culture-proven pyelonephritis, febrile presumptive UTI. So, presumptive UTI yung patient, wala kang culture, pero meron kayo urinalysis findings, clinical findings, tas may fever, technically kailangan mo ng ultrasound. Or recurrent UTI. Other tests, you can do your VCUG, your voiding cystourethrogram to check for reflux, renal scans, and acute phase reactant as needed. Okay? These are the management recommendations from your DOH guidelines. Sorry, this is from Nelson's pala. Si Nelson, cystitis, pwede pang Cotri, nitrofurantoin, and amoxicillin. However, in clinical practice here in the Philippines, medyo mataas na yung resistance sa tatlong to. We usually do second-generation cephalosporin such as cefuroxime or your coamoxiclav. For pyelonephritis, it's IV treatment. You can do your ceftriaxone, cefotaxime, ampicillin plus aminoglycoside, okay? You can give oral, okay, but it does not cover for Pseudomonas. So, pag nag-iisip ka ng Pseudomonas, previous antibiotic use, o kaya mga hospital-acquired infection, then it's better to do your IV antibiotics with coverage for Pseudomonas. Okay? Because if you have Pseudomonas, add your aminoglycoside or fluoroquinolone. DOH recommendations, ayan, pag less than 2 months old, cefotax plus amic. So, para siyang neonatal sepsis, ampigenta. Ito, cefotax amic. 2 months to 18, coamoxiclav, sinabi ko kanina, cefuroxime, ampicillin sulbactam. Nitrofurantoin, also an option. Pag recurrent, catheter-related, tapos Pseudomonas, ceftri plus amic, 7 to 14 days. When do you switch? If you do not have clinical response in 48 to 72 hours. Okay? I'll now run you through acute kidney injury as this has been asked, I think three years ago. So, AKI is defined. AKI is defined as an abrupt loss of kidney function leading to a decrease in your glomerular filtration rate. So, yun yung pinaka-definition niya. Abrupt loss of function, decrease GFR. So, pag bumagsak yung filtration rate mo, your waste products will accumulate such as your BUN, CREA, and then all of this dysregulation will happen. Okay? So, you have your KDIGO definition, and ito yung nasa Nelson. So, ito yung tatandaan natin for the exam. So, it is defined by increase in CREA by more than 0.3 mg per deciliter from baseline within 48 hours. So, within 48 hours of your injury, tumaas siya ng 0.3, or increase in CREA to more than 1.5 times within the prior 7 days, okay? Or urine volume less than 0.5 ml per kilogram per hour for 6 hours. So, 6 hours siyang mababa ang urine output, okay? So, you have criteria of staging of KDIGO for your acute kidney injury. You have 1, 2, and 3, okay? So, 1 is, ito yung definition nga natin, di ba? Less than 0.5 for 6 hours. So, 6 hours to 12 hours. So, you can either use your CREA or your urine output, okay? 1.5 to 1.9 times from the baseline or more than 0.3 increase. So, ito yan, di ba yan? More than 0.3 increase from the baseline, 48 hours, more than 1.5 for the past 7 days. Kapag 2 to 2.9 times the baseline, that's stage 2. Kapag more than 12 hours ka ng less than 0.5, stage 2 yan. 3 times from the baseline or your serum creatinine is more than 4 mg per deciliter. Okay? Or nag-initiate ka na ng renal replacement therapy such as dialysis or yung GFR mo mababa. Or 0.3 ml per kilogram more than 24 hours na or hindi siya umiihi for 12 hours. Then that is stage 3. Okay? And do remember, you have different causes of pre-renal. Pag pre-renal ang problema mo, different causes of AKI. So, you have different causes of AKI, which is pre-renal, intrinsic renal, post, and tumor lysis syndrome. It's considered a specific form of AKI. Okay? So, daanan natin isa-isa in this, again, beautiful table, which summarizes basically most of the things that you need for the exam. Okay? Pre-renal, guys, tandaan nyo, Ang problema dito is because of your defective or decrease in effective circulating volume. Kailan nangyari yan? Dehydration, sepsis, bleeding, okay, cardiac failure. Kapag decrease yung blood na pumapasok papunta sa kidney, it will cause renal injury. That is pre-renal. Intrinsic renal is renal parenchymal damage, okay? Including sustained ischemia, meaning pag sobrang tagal nung pre-renal mo na ischemia or sepsis or dehydration, magiging intrinsic renal damage din yan eventually. Example, glomerulonephritis, okay? Or toxins. All of this can cause AKI. Post-renal, think of obstruction. So, pag meron kang obstruction ng urinary tract mo, that will cause post-renal AKI. And again, tumor lysis syndrome, this happens in patients with solid tumors being treated for chemotherapy. Pag na-treat sila, nagkakaroon ng lysis, lumalabas yung mga electrolytes nila, then you will have TLS, tumor lysis syndrome. Okay? Kanina, AKI, now let's go to your chronic kidney disease. Kanina, Kidaigo, eto naman ngayon, Kidoki. Okay? Yung Kidoki criteria mo, patients with CKD either has the following criteria present. Damage for more than 3 months, kaya siya chronic. Okay? Defined by structural or functional abnormalities of the kidney with or without GFR, manifested by one of the more following features. So, with or without decrease in GFR. So, ang cutoff mo dito again, kidney damage for more than 3 months, defined by structural or functional abnormality with or without decrease of GFR, and ito yung manifestation. Abnormalities in the composition of blood or urine, imaging tests, biopsy findings. Okay? So, either this or GFR of less than 60 for more than or equal to 3 months, with or without other signs of kidney damage described above. Okay? They have a staging, dati ang tawag dito rifle, di ba? Risk, injury, failure, loss, and stage. Ngayon, 1, 2, 3, 4. Okay? So, ang basis niyan is GFR. So, 90, 60 to 89, 30 to 59, 15 to 29, less than 15. Ang palatandaan ko dito nung minememorize ko tong criteria na to, 90, 60, 30, 15. Okay, madaling tandaan, di ba? 90 is stage 1, 60 stage 2, 30 stage 3, 15 stage 4, less than 15 is stage 5. Okay? So, damage with normal or increased GFR, with mild decrease, moderate decrease in GFR, severe decrease in GFR, and stage 5 is kidney failure. Okay? So, I hope that's clear, the different criteria of acute kidney injury and chronic kidney disease. Okay, 9-year-old boy presents with a 5-day history of abdominal pain and diarrhea, bloody stools, nag-IVF replacement, nawala yung abdominal pain, umokay na siya, kaya lang biglang nagkaroon ng gross hematuria, tapos pallor. Okay? On blood smear, very important, there's fragmented RBC. What disease are you thinking about? Okay, nagka-diarrhea, tapos nagkaroon ng hematuria. Okay? Tapos anemia. Okay, kulang na lang dyan thrombocytopenia. That is your HUS, hemolytic uremic syndrome. And the most notorious cause would be your enterohemorrhagic E. coli, lalo na pag kumain ng hamburger. Remember the triad: microangiopathic hemolytic anemia, thrombocytopenia, and renal insufficiency. The mnemonics for HUS is RAT, R-A-T, renal insufficiency, okay, or renal failure, anemia, and thrombocytopenia. But do take note, not just any form of anemia. Dapat microangiopathic hemolytic anemia. Okay? So, microangiopathic hemolytic anemia. Different causes can be infection, drugs, pwedeng yung mga toxins ng E. coli, pwede rin Shigella. Okay? So, most common form is again from your E. coli. Okay? So, how is it different from your TTP? Your TTP is usually in older children or adults, adolescents, okay? TTP will present with fever and CNS involvement, okay? And usually more gradual yung onset niya. So, kung ang HUS is rat, ang TTP is fat RN, matabang nurse. F is for fever, anemia, thrombocytopenia, RN, renal failure, and neurologic symptoms. Okay? So, to diagnose HUS or TTP, there is a laboratory criteria. Both should be present. Anemia with microangiopathic changes. Ang nangyayari kasi guys sa HUS at TTP, namamaga yung glomerulus, namamaga yung mga vessels, tapos pagdaan ng mga red blood cells, naiipit sila, nasisira sila, kaya yun yung tinatawag na microangiopathic changes. And renal injury. Ito yung mga criteria niyan. There is what we call confirmed and probable. Para hindi kayo malito, dun muna tayo sa confirmed. Diagnosis of HUS or TTP clinically that meets laboratory criteria, okay, that both meets laboratory criteria and began within 3 weeks after an episode of bloody diarrhea. Okay? Kapag hindi mo na-fulfill lahat yan, example, nagkaroon ka ng signs and symptoms ng HUS or TTP pero wala kang history ng bloody diarrhea. Okay? Or may history ka nga pero hindi mo naman na-fulfill yung dalawang laboratory criteria, which is microangiopathic changes and renal failure, then probable HUS lang siya. Okay? Again, remember, it is the hallmark, your microvascular injury in all forms of HUS. So, yan. Thickening of the capillary walls because of the inflammation. Tapos, nagkakaroon ng mga deposits. Kapag dumaan yung red blood cells, you have mechanical damage as they pass through the altered vasculature. Okay? Thrombocytopenia happens because of your platelet adhesion or damage. Okay? It is usually sudden onset. And actually, guys, prognosis is very guarded for these patients. Okay? So, on PE, you have dehydration, organomegaly. Again, for peripheral for peripheral smear, these are what you look for. These are your signs of your microangiopathic hemolysis. You have your helmet cell, your Burr cells, or fragmented RBCs. Management is supportive. We usually do not give antibiotics. Most of the time, it increases toxin release, makes the patient more toxic. We usually do not transfuse platelet kasi sisirain lang din yan. Usually supportive dialysis, BP control, fluid and electrolyte management. I've only seen 4 cases of HUS during my training. All of them passed on. So, medyo complicated mag-manage ng HUS. Okay? If this patient survive long-term prognosis, they are prone to developing long-term sequelae such as renal insufficiency, hypertension, and proteinuria. And that ends our nephrology section. Okay? We now go to our last segment of this review, which is hematology and oncology. Which type of leukemia will have the best response to chemotherapy? And actually, this is the most common type of leukemia in children. The most common malignancy in children is leukemia, followed by your brain tumors. Okay, the most common malignancy again in children is leukemia. The most common type of leukemia is your ALL, and it will actually have the best response to chemotherapy. Okay, so you have to know by heart ALL kasi malamang dito sila magtatanong. Okay. It's usually acute in onset, so less than 4 weeks. So huwag kayong magulat pag after, wala pang, ang history ng lola is 2 weeks pa lang yung symptoms. Pag check mo, bagsak na yung hemoglobin niya, yung platelet niya, then that's common, typical of ALL. Non-specific signs and symptoms, you have signs of marrow failure and signs of infiltration. When you say marrow failure, signs of marrow failure, so you have anemia because bumababa yung kanyang red blood cells. You have bleeding because bumababa yung platelet, and then fever, infection dahil bumabagsak yung kanilang WBC. Remember, you diagnose leukemia usually with pancytopenia, meaning 2 or more cell lines are affected. So, pancytopenia is 2 or more cell lines na affected. Ano ba yung cell lines mo? You have your RBCs, your WBC, and your platelets. Okay, yun yung tatlong yon. And in leukemia, you have signs of infiltration. So, bone pain, joint pains, lymphadenopathy, and organomegaly. This is very important because you have another type of hematologic disorder which causes pancytopenia pero wala siyang signs of infiltration. Are you familiar with aplastic anemia? Okay, so one clinical way to differentiate the two, aplastic anemia also presents with pancytopenia, is that aplastic anemia will not have signs of infiltration most of the time. Okay? So, pancytopenic siya pero walang infiltrative signs. Think of aplastic anemia. Versus ALL, meron siyang infiltrative signs. Okay? Of course, how do you diagnose and differentiate between the two? It's biopsy. In ALL, what you will see is hyperproliferative bone marrow with blasts or immature cells. In aplastic anemia, you have hypoproliferative hypocellularity, okay? Hypocellularity and fatty infiltration. Okay? So, malinaw yun. ALL versus aplastic anemia. So again, ALL is hypercellular, hypoproliferative, ang daming cells pero immature. Aplastic anemia is hypocellular, kukunti yung cells, tas puro taba, fatty infiltration. Okay? So, findings of your ALL results from the leukemic expansion and crowding out of your normal marrow. Your normal marrow is being replaced by blast cells, and your blast cells, they do not have function because they are immature. Okay? So, yan. So forth and so on. Fever, dahil yung mga pyrogenic cytokines mo, and then you can have involvement of your organs. So, nagkakaroon ka ng organomegaly. Okay? The most important, tumanong to sa exam 2 years ago, the most important, single most important prognostic factor is the response to treatment. Okay? 3 of the most important predictive factors is the age of diagnosis, initial leukocyte count, and the speed of response. Again, treatment is the most important. Average risk is 1 to 10 with a leukocyte count of less than 50,000. Tinatanong din yan. And ito yung tanong specifically, ano ba yung mga poor prognosis? Less than 1, more than 10? Male. Unfortunately, pag lalaki, that's poor prognosis for ALL. WBC, more than 50,000 on diagnosis, CNS leukemia, or the presence of mediastinal mass. Okay? So please remember this. This is a very heavy slide. Ang daming tinatanong dito. Okay? Spread. Saan kumakalat? Liver, spleen, and lymph nodes. Relapse. Gumaling na. Pero nagbumalik. Saan usually yan? Bone marrow, CNS, and testicular relapse. Okay? So wag mo papalitin. Relapse is bone marrow, CNS, testis. Spread is liver, spleen, and lymph nodes. Okay? Next case, you have a 2-year-old for pica and pallor. Namumutla, tapos pica is eating objects na hindi naman dapat kinakain. Okay? Poor activity and appetite, irritable, purely milk diet, and we see this a lot. So, ito yung mga batang hindi na transition from complementary feeding to solid feeding. So, puro milk yung natira. And the most common cause of anemia in children, it's nutritional, specifically for children less than 2, it's your iron deficiency anemia. Okay? So, iron deficiency anemia presents with microcytic hypochromic anemia, and that's very important. Okay? Anemia is defined by the reduction of hemoglobin, okay, or RBC volume below the range occurring in healthy persons. And why is this important? Because in pediatrics, again, it's compared against norms. Okay? So, ang problema sa pedya, depende sa age, nag-iiba-iba yung mga normal values. So, dami, no? Dok, kailangan ko ba i-memorize to sa exam? Technically, oo. Okay? Pero I don't think magtatanong yung examiner nyo ng ganyang ka-detailed na question. Ang mas kailangan nyo i-memorize is the differential diagnosis if you have a patient presenting with anemia, and how do you approach them. When you have a patient with anemia, one way of classifying them is to see the size of the red blood cells. We can classify it as normocytic, microcytic, and macrocytic. Okay? Microcytic, mag-focus tayo dito because this is where your IDA is. This is where your thalassemia is. Yan yung mga pinaka-common na tinatanong sa exam. Okay? The next thing that you look for after checking the size of the cell is the reticulocyte count. Okay? Please remember, reticulocytes are immature RBCs. In response to anemia, ano ang nangyayari? Dapat yung reticulocyte nyo tumataas o bumababa? Dapat tumataas as a compensation. Pag may anemia kayo, yung bone marrow nyo magpo-produce ng mas maraming reticulocyte. Okay? If you have anemia but your reticulocyte does not increase, if it goes down or remains to be normal, what does it tell you? It tells you that you have a problem in your bone marrow. So again, let's make it clear from the start. Okay? Kapag may anemia ka at hindi tumaas yung reticulocyte, then probably you have a problem with your bone marrow. Okay? So, anemia, check your CBC, peripheral smear, and reticulocyte. If your reticulocyte is low and you are microcytic anemia, then think of your maturation disorders. Okay? If may bleeding ka, or may anemia ka, tapos tumaas yung reticulocyte mo, think of hemolysis or hemorrhage. Okay? Hemolysis such as autoimmune hemolysis, such as your spherocytosis. Okay? Kapag mababa yung reticulocyte mo pero normocytic, think of bone marrow damage. Okay? Normocytic cells, infiltration, aplastic anemia. Okay? So, again, this is a very important flowchart that you can use to differentiate the different types and diagnosis for anemia. Okay? Okay, so there are different approach, and again, this flow chart, you can use this, but what I usually do again is I usually follow this one from Nelson's. I think it's more simple, although parang ang gulo lang, di ba? Pero again, if you have a patient with anemia, always look at the size first and then look at the reticulocyte. Okay? So, think kapag normal yung reticulocyte, that is probably hemolysis or hemorrhage. Okay? Kapag hindi, then think of a bone marrow problem. So, etong mga to, wala namang problem sa bone marrow. But because of these deficiencies or disease entities, for example, IDA, thalassemia, folic deficiency, hindi makapag-synthesize yung bone marrow. So, in essence, it still boils down na yung pathology mo na sa bone marrow. So, kunwari, IDA, okay yung bone marrow pero wala kang iron, hindi makabuo ng reticulocyte yung bone marrow mo. As compared to this one, wherein healthy yung bone marrow mo, they produce reticulocyte, your problem causing the anemia happens elsewhere. Autoimmune, nasisira yung RBC sa labas ng bone marrow. Main membrane defects, pagdating sa spleen, sisirain ng spleen yung mga defective RBCs mo. Okay? Hemoglobinopathies, the same. And metabolic changes, it's still outside the bone marrow yung problem. So that's one way of classifying it. But again, for the exam, most of the time, ito yung tatanungin sa inyo. Micro, normo, macro. Macrocytic, folic versus B12 lang yan. Madali lang yan. Folic deficiency, walang neurologic deficits. B12 meron. Normocytic, it's your chronic disease, but actually, in the long run, your chronic disease will go here. Okay? Mapunta siya dito. So, normocytic anemia is usually uremia, hypothyroidism, or bone marrow failure. Okay? So, dito tayo iikot sa exam. Malamang sa malamang dito yan. Microcytic. Remember, 80 to 100 is the normal. Less than 80 is microcytic. Okay? That's your MCV. Thalassemia and IDA, you have to know to differentiate them apart. Okay? And other microcytic anemias are lead poisoning, sideroblastic, and anemia of chronic disease. Again, the mnemonics is tails. Okay? Another mnemonic for that is CLITS, C-L-I-T-S, CLITS. Okay? Chronic disease, lead poisoning, IDA, thalassemia, sideroblastic anemia. Okay? So, kung anong mas gusto nyong tandaan, tails or CLITS, whichever floats your boats, kung saan nyo mas maaalala. Okay? So, IDA is the most common disease, hematologic disease of infancy and childhood, common from 9 to 24 months of age. Dietary ang problema. Pallor is the most important sign, but it only happens or usually nakikita siya pag nasa 7 to 8 grams per deciliter na yung level nyo. Meaning you can have anemia na walang pallor. Okay? At 6 to 10 kasi may compensatory mechanisms ka pa. These compensatory mechanisms make it so na hindi lumalabas pa yung signs and symptoms. Almost no symptoms. Okay? But at 5, lumalabas na yung anorexia, irritability, and then if you do not manage this, you can have dilatation, murmurs, tachycardia, and the long-term effects of anemia. IDA also causes non-hematologic effects such as pica. So, IDA ka na nga, anemic ka na nga, kakain ka pa ng lead paint, magkakaroon pa ng lead poisoning, double whammy ka na. Pagophagia is eating ice. So, hilig kumain ng ice, no? Neurocognitive effects, studies have shown that the neurocognitive effects of IDA is irreversible. Meaning, mga batang never nagka-IDA versus mga nagka-IDA tas nagamot na, they have lower neurocognitive scores, okay, compared dun sa mga never nagka-IDA. And that's why it's very important to treat them. On diagnostic findings, you have low reticulocyte, okay, microcytic hypochromic RBCs, high RDW, low serum iron, ferritin, high TIBC. Okay, how do you differentiate this from thalassemia? Okay, thalassemia is also microcytic hypochromic. Okay, thalassemia will also have low reticulocyte count. There are some types of thalassemia with high reticulocyte count, but majority of thalassemia will have low reticulocyte count. Okay, short of checking, of course, for your iron and ferritin levels or your TIBC. Okay, one very important way to differentiate them in board exam questions is, even in clinical practice, is to look at your RDW. Your RDW is red cell distribution width. Okay? It tells you how varying the sizes of the red cells are. In IDA, you have microcytic hypochromic anemia and the sizes of the red blood cells are very different. Malalaki, maliliit, malalaki, maliliit. Therefore, having high RDW. Okay? In thalassemia, it's also low retic, microhypo, pero RDW is normal. Okay, so please remember that. Because in the board exam, if you're not given values of ferritin and iron, TIBC, serum iron, and you're only given reticulocyte count, and then the red cell indices, you can check for your RDW. Mataas na RDW, probably IDA. Normal na RDW, probably thalassemia. Okay? TIBC is important to differentiate IDA from chronic disease. Okay? TIBC is high in IDA, it's low in chronic disease. Both will have low iron levels. Okay? And this is also a favorite exam question. These are the pathophysiology. This is the pathophysiology of iron deficiency anemia. Okay? Take note of ferritin and transferrin, wag pagpapalit-palitin. Please remember that ferritin is for storage, transferrin is for transport. Okay? So, mauubos yung iron stores mo, hemosiderin will disappear. Your ferritin, again, is for storage. Ano mangyayari sa ferritin? Tataas, bababa. Wala ka na iron. Okay? Kailangan mo ng iron, kailangan mo mag-mobilize ng iron, wala kang iron. So, bababa yung ferritin mo kasi hindi mo kailangan mag-store. Kailangan mong gamitin yung iron mo. Okay? Your iron level will decrease kasi nga, that's part of IDA, di ba? The iron deficiency anemia. Okay? Your total iron binding capacity. What do you think will happen to this? Will it increase or decrease? Okay? Kailangan mo ng iron. Kukunti yung iron mo. So, to compensate, you will try to increase the binding capacity. Tataas yan. Okay? Transferrin is for transport. Hindi mo kailangan ng storage, pero kailangan mo mag-transport. Kailangan mo immobilize yung iron. Therefore, it also increases. Your percent saturation, okay? Ang dami mong transport protein, tinaasan mo yung binding mo, but the fact still remains na kukunti yung iron mo. So, what happens to the percent saturation? Kahit sobrang dami mong protein na per transport, yung percent saturation mo dahil kukunti nga yung iron mo, babagsak siya. Naintindihan nyo? So, remember the story para mas madaling matandaan kung tataas ba yan o bababa. Para pag tinanong sa exam, masasagutan natin. Okay? And then after this, okay, your FEP will increase, your RBCs become smaller, hemoglobin content becomes lesser, you end up with microcytic and hypochromic anemia. Okay? Prevention is better than cure. That's why we give routine prophylaxis for iron deficiency anemia here in the Philippines. But if you do have your IDA already, this is the treatment. The dose is 3 to 6 milligram per kilogram per day of elemental iron. Okay? For mild anemia, we repeat after 1 month, and usually it will increase by 1 to 2 grams per deciliter. Characteristically for IDA, the more severe your anemia is, the faster the response to iron therapy. Okay? If your patient is not responding, then probably you have a different diagnosis or you have other confounding factors. For example, may intestinal parasitism pala siya, meron pala siyang GI bleeding, so you have to address those as well. It is very rare that we transfuse for IDA, but for severe cases, yes, pwede. Okay? And this is also a favorite board exam question, response to therapy. First 12 to 24 hours, there is subjective improvement. Nawawala yung irritability, yung anorexia. 26 to 28 hours, you have initial bone marrow response. In 3 days time, saka ka pala nagkakaroon ng reticulocytosis. In 1 month time, tumataas na unti yung hemoglobin. That is why you repeat after 1 month. And it will take 3 months to replenish your iron stores. That is why 3 months dapat minimum yung treatment. Okay? And this is my last slide. A very beautiful slide for Wilms versus neuroblastoma. Laging tinatanong to sa mga solid abdominal tumor. Wilms is renal in origin. Neuroblastoma can arise anywhere along your neural axis, but most commonly in the adrenals and sympathetic ganglia. Okay? Wilms usually does not cross the midline. Neuroblastoma, dahil kung saan-saan siya tumutubo, tandaan nyo kung saan-saan siya tumutubo, then it can cross the midline. Both will have hypertension, both can have hematuria, but neuroblastoma is associated with a gamut of different signs and symptoms na kung minsan maguguluhan ka na bakit ganito to. Pwede siya magka-cord compression, periorbital bruising, nodules, opsoclonus, myoclonus. Okay? But Wilms, because it's renal, most of the time, ang mga associated signs and symptoms niya, hematuria and hypertension lang. Metastasis is lungs for Wilms, for neuroblastoma, it's bones. Diagnosis of course, biopsy, but for neuroblastoma, you also do your VMA and HVA. Therapeutics, similar yan. Surgery plus or minus chemo, radio. Okay? I hope you learned a lot. I hope you're able to process everything that I've taught you. Dr. Ruby Punong Bayan will have a very good discussion for the second part of pediatrics as well. Okay? I will see you soon on my next lectures. I'll still have pearls to discuss. I will be having a face-to-face lecture, if I'm not mistaken. So, thank you very much for listening, guys, and good luck on your pediatrics review.